Moving on to the next session, which is research and anesthesia. Uh, the first part of it is the fresh perspective, cutting edge research in anesthesia. To moderate and facilitate this session, I would like to invite Dr. Huba Ahmed on the stage, please. Oh, okay. I would like to remind that the e-posters are at the back of this hall, which is the ballroom B. So those who are presenting the e-posters, we have all of them already, but go and check it on the kiosk as well. Thank you.
Assalamu alaikum and a very good morning to all the distinguished guests. It gives me great pleasure to welcome you to this session, Fresh Perspectives, Cutting Edge Research in Anesthesia. I am Dr. Huba Ahmed and I have the privilege of facilitating this intellectually enriching session where we will be hearing impactful talks on two ever-emerging areas in anesthesia. Before we begin, it is my honor to introduce the chairpersons of our session. I would like to invite Dr. Akhtar Aziz Khan, a very senior anesthetist, currently working as CEO at Kutiana General Hospital. I would also like to invite Dr. Jawda Salim, President PSA Lahore chapter, working as Professor of Anesthesia at Lahore General Hospital. We are privileged to have their guidance and insight during this session.
So we are starting with the session, and the topic is Fresh Perspective, Cutting Edge Research in Anesthesia. And we have our first talk by Dr. Numan Akil from Ziauddin University, Advancement in Pediatric Trauma Resuscitation.
Good morning. I'm Dr. Mohammad Numan Akil from Ziauddin University Hospital. I would like to thank the Pakistan Society of Anesthesiologists for giving me the opportunity to present in this new format introduced this year. This session is focused on recent research and advancement in the field. For my presentation, I'll be discussing the pediatric trauma resuscitation. To support this, I conducted a thorough literature search using PubMed and different resources. As the original studies over the last 5 years were limited, I selected a 2023 systemic review from the Journal of Acute Trauma and Acute Care Surgery as the main reference. It compiles multiple relevant studies and provides a strong evidence base for this topic. Pediatric damage control resuscitation follows the same fundamental principle as adult, but early recognition is more difficult due to children's ability to maintain normal vitals despite severe bleeding. Literature indicates a 36 to 50% mortality rate in children with hemorrhagic shock, significantly higher than adults. Hypertension relied upon is a late indicator and occurs only after a loss of over 40% of blood volume. This underlines the importance of proactive intervention and vigilance. Recent multi-institutional observational data highlight critical time delays from recognition of life-threatening hemorrhage to RBC transfusion took a median of almost 8 minutes. Plasma administration took 34 minutes and platelets 42 minutes. The average massive transfusion protocol duration was 3 hours. These delays likely raise pediatric trauma mortality, stressing the need for earlier recognition and faster resuscitation protocols. In the pre-hospital setting, pediatric patients needing damage control resuscitation are infrequent. This rarity leads to less exposure and training for EMS personnel, contributing to delayed recognition and intervention. Establishing intravenous access in children is challenging, and the alternative intraosseous access is still underused. These challenges, along with limited research, hinder the development of standardized protocols. There has been a significant shift in trauma resuscitation guidelines. Both national recommendations and the latest ATLS edition discourage multiple crystalloid boluses. Overuse of crystalloid in children with hemorrhagic shock has been linked to increased complications. Instead, early blood product transfusion is preferred. Studies, although limited in scale, support the safety and feasibility of pre-hospital transfusion, showing improved physiological outcomes on hospital arrival. The landmark study by Morgan et al. In 2023 was the first to show a mortality benefit of pre-hospital transfusion after matching 24-hour mortality was 16% with pre-hospital transfusion versus 25% in emergency department transfusion. In-hospital mortality was lower in pre-hospital transfusion, which was 20% versus 32%. This highlights that early resuscitation close to injury time can significantly improve survival. Pediatric hemorrhagic shock management focuses on limiting crystalloids and prioritizing blood products, especially balanced components. Excess crystalloid cause hemodilution and worsens coagulopathy. Low titer group O whole blood offers a more physiological alternative when available. A major study using trauma quality improvement program data demonstrated that children who received plasma in higher ratios relative to RBCs had significantly lower 24-hour mortality. This reinforces the importance of initiating balanced transfusion early. Ratios closer to 1:1 seem most protective. Lower plasma contribution, less than 1:2 ratio, correlate with significantly worse outcomes. A major beyond sorry a major is sorry Beyond ratios, the absolute plasma deficit, how much more RBC is given than plasma per kg, has been shown to influence mortality. A greater plasma deficit was associated with worse outcomes. While not all studies found significant associations, most negative results came from small, single-center cohorts lacking proper statistical adjustments. Platelets are important for coagulation and as well as for endothelial stabilization. However, most studies haven't shown a clear survival benefit from high platelet ratios. Interestingly, the deficit rather than the ratio has shown stronger correlation with outcomes. This suggests that under transfusion may be more relevant than ratio imbalance alone. Evidence from adult trauma such as pragmatic randomized optimal platelet and plasma ratios trial emphasizes the value of early and balanced component use, especially with platelets. Pediatric data are less robust but increasingly point in the same direction. These findings underscore the need for early recognition and immediate initiation of hemostatic resuscitation with a focus on component balance and minimizing deficits. Low titer group O whole blood is a promising option for pediatric trauma resuscitation. It provides higher hemoglobin, platelets, and clotting factors with fewer additives, reducing coagulopathy and hypocalcemia. It can be given through a single line, which is helpful in kids. It is now endorsed by guidelines and used in many US centers. Study shows low titer group O whole blood help resolve shock and coagulopathy faster, reduces transfusion needs and ventilation time, and lower both 72-hour and 28 days mortality. While more research is needed, current data support its use in pediatric trauma care. Tourniquets are recommended for life-threatening extremity hemorrhage and have shown survival benefits without major complications. Still, standardizing application is key. Topical adjuncts such as hemostatic gauzes can aid bleeding control in challenging areas but are not extensively studied in children. Transamine is a powerful antifibrinolytic with strong safety evidence in surgical settings. Its trauma use in pediatrics remain limited. Although recent multi-center data show early transamine may reduce short-term mortality. Consensus suggests transamine may be considered if given within 3 hours. More consistent implementation in pediatric trauma protocols may be beneficial. Cryoprecipitates provide essential clotting factors and may boost early survival, particularly in severe trauma. Pathogen-reduced versions improve availability, while pediatric trials are still needed to confirm long-term safety. The MATIC study showed cryoprecipitate independently associates with lower 24-hour mortality after adjusting the confounders. This slide highlights the importance of early massive transfusion protocol activation in pediatric trauma. Balanced resuscitation with components or low titer or whole blood improves transfusion practices and speeds up blood delivery. While mortality benefit isn't consistently shown due to small studies, safety data supports continued use. This slide represents a framework for implementing pediatric damage control resuscitation. Emphasize the need for a team-based approach, starting with education to align understanding. A core team should review local data, MTP use and resources, highlight the importance of updating protocols, simulation training, and continuous quality improvement to drive effective resuscitation practices. MTP activation teams are formed to provide structural rapid response supports during massive transfusion events, especially in children. The surgeon helps assess and manage surgical causes of bleeding, while the pharmacist ensures timely administration of transamine and calcium and reinforces lab monitoring. Nursing leadership plays a vital role by handling rapid infusers and warmers, maintaining accurate records, and speeding up blood delivery from the blood bank. This team-based approach improves efficiency, safety, and standardization during rare but high-stakes scenarios. Implementing hemostatic resuscitation in children faces key challenges. Evidence is limited, but the MATIC-2 trial will provide needed data on low titer, group O whole blood, and transamine. Early life-threatening hemorrhages recognition also remains difficult. Rhesus D negative group O whole blood is scarce, leading to debate on using Rhesus D positive in young females, though many families accept the risk when balanced against potential survival benefits. In conclusion, there is a pressing need for well-designed prospective trials to investigate trauma-induced coagulopathy and evaluate outcomes of hemostatic resuscitation in pediatric patients. Pre-hospital care plays a critical role, so modeling and capturing time-sensitive data is essential for early recognition and treatment of hemorrhagic shock. From a systems perspective, standardizing and improving data collection across pediatric trauma programs will help guide evidence-based interventions and ultimately improve survival outcomes. Thank you.
Thank you, Dr. Numan. Now I request the next speaker, Dr. Waleed bin Ghaffar from Khan University. He's going to talk about ARDS in the last decade, key development and breakthroughs. And we'll have a question answer session at the end of this talk.
Assalamu alaikum. So I have to present 10 years of data in approximately 10 minutes. So my aim will be to focus on the key insights which can be applied at the bedside for patients with ARDS. So first of all, I do not have any conflict of interest. So starting from the introduction, ARDS was first recognized as distinct condition in 1960. And when we talk about the burden of the disease, so it encompasses about 10% of the ICU admission, and the global mortality is 35 to 46%. So to give this percentage, to present this percentage in number in the form of number, so the data from USA states that approximately 74,500 mortality per annum are secondary to this condition. And when it comes to data from the Pakistan, so Pakistan is leading the way with range from 36% to 65%. So starting from the trend, so as per the trend, there is no local data, and data from the Europe of the 93,000, approximately 93,000 patients, we can see from 2000 till 2015, there was approximately 1% decline per annum in the incidence of ARDS. And then in 2019, COVID-19 happened, and we can see a sudden surge of ARDS. But when we compare this data to the mortality, so in the mortality, there was also decline in the mortality, but post-COVID from 2021 and beyond, there is rise in the mortality. So regarding the definition, so after the presentation of the previous definitions in 1988 and 1994, in 2012, the Berlin definition was presented, and all of us have read about this. So it it is based on the criteria of timing, chest imaging, origin of edema, and oxygenation. So for oxygenation, it categorized by PaO2 and FiO2 ratio. So for this, in 2015, Kegeli modification was introduced, which introduced SpO2 FiO2 ratio. So why this was helpful? Because it was applicable to resource constrained settings where ABG's machines are not available. So in 2023, there was new global definition of ARDS. In this definition, they included all the parameters of Berlin criteria, and in addition to this, they presented some additional parameters. So on the top, PF ratio of less than 300 or SpO2 FiO2 ratio of less than 315 with SpO2 of 97%. So why they have limited the SpO2 of 97%? Because beyond that, oxygen hemoglobin dissociation curve becomes flat, so it is not practical. And unlike previous guidelines, which included only chest X-ray or CT scan, they have also included lung ultrasound for chest imaging. And along with that, high frequency oxygenation ventilation. And for the resource limited settings, they are saying that we can avoid PEEP, oxygen flow, or specific respiratory support devices for inclusion of these patients. So based on the new parameters and the new definitions, we are accepting and including more patients with ARDS. So in coming years, based on the new definition, we may see a rise in the data of ARDS. So pathophysiology, what we knew before 2014, that it's immunoinflammation. So secondary to inflammatory response, there is surfactant dysfunction, capillary leak, diffuse alveolar damage, which can be shown in this simpler version of the diagram. So what changed from 2014 till 24, that there was also immunothrombosis, which was seen in COVID-19, that there was microvascular thrombosis leading to clot formation in the pulmonary capillaries, which led to dead space ventilation. So previously there was only shunting, but now we are also seeing dead space ventilation. Regarding the phenotypes, so all of us knew that it's a heterogeneous disease, but in the last decade, two subphenotypes were introduced based on the biomarkers. There is hyperinflammatory, hypoinflammatory, and in the previous 2 years, there is emergence of a third phenotype, which is rapidly evolving, improving ARDS. So when you compare hyper versus hypoinflammatory subphenotype, in the hyperinflammatory phenotype, there is increase in mortality and decrease in ventilator-free days. So this leads to worsening in the outcome. So how can this subphenotype classification help us? So answer is simple: precision medicine, because it seems like hyperinflammatory ARDS may respond better to targeted therapies, including high dose steroids, interleukin 6 inhibitors, and some of the newer experimental drugs. Coming to the management of oxygen therapy, so in the past, oxygen therapy was liberal, it was guided by clinical judgment. In the last decade, we have seen some of the trials which have shown benefit of the conservative oxygen therapy, but they included patients only with acute respiratory failure. But LOCO-2 trial was conducted only in the patients with ARDS, and in this trial, there was harm with conservative oxygen therapy. So that's why the current consensus recommends avoiding both hypoxemia and hyperoxia and maintain the oxygen saturation between 92 to 96%. Coming to respiratory support strategies, so in the past, NIV was favored for acute respiratory failure, but it was not favored for ARDS. In these patients, intubation was favored. But in the last 10 years, we have seen multiple trials which have shown benefit of NIV and high flow nasal cannula. And the key highlights are high flow nasal cannula was non-inferior to NIV, it was better tolerated, and it also reduced the 90 days mortality. So based on all these trials, the recommendation by all the major guidelines are they favor high flow nasal cannula, but they also recommend validation of scoring for high flow nasal cannula, which is ROX index, that we have to use variables of SpO2, FiO2, and respiratory rate. Based on this, we'll calculate the ROX index at 2 hours, 4 hours, 6 hours, and eventually at 12 hours. And if at any time the index is less than 3.85, then we'll have to intubate the patient. Coming to mechanical ventilation strategies, in the past, the famous ARMA ARTSNet protocol was published, based on which mortality was decreased, and which suggested tidal volume of 6 ml per kg and plateau pressure limit of 30 centimeter water, which led to decrease in mortality. So in the last 10 years, we have seen concept of driving pressure, that if we limit the driving pressure less than or equal to 15 centimeter water, it also reduces the mortality. There is also concept of mechanical power, which refers to the amount of energy per unit of time transmitted to the respiratory system by the mechanical ventilator. And when we talk about PEEP, there is mixed data on PEEP. PEEP titration via esophageal pressure EP vent trial was inconclusive, but still guidelines suggest there, that individualized approach is better. When we compare the ventilation modes in the past, only two modes were compared, but in the last 10 years we have seen pressure regulated volume control, but there was increased risk of desynchrony. In the airway pressure release ventilation APRV mode, multiple trials have been conducted, and they have shown APRV improved oxygenation, compliance, and it shortened the mechanical ventilation duration. So recruitment maneuver is applied to the patient with ARDS to open the collapsed alveoli. But is it beneficial, or it brings harm to the patient? So in the past, multiple trials were conducted. The summary was that recruitment maneuvers improved the oxygenation in this patient, but there was no mortality benefit. So in the last 10 years, we have seen again many trials which have assessed this. So again, oxygenation was improved, but the ART trial, which included approximately 1,000 patients, it showed that there was increase in mortality. So that's why the current guidelines suggest there is strong recommendation against the use of lung recruitment by American Thoracic Society, Society of Critical Care Medicine, and European Society of Intensive Care Medicine. But they do suggest that we can consider in refractory hypoxemia with recruitable lung. Prone ventilation, so we have seen its benefit. It was shown by ProSiva trial, which showed the mortality benefit. And in the last 10 years, we have seen multiple meta-analysis which have reaffirmed the benefit of prone ventilation. And in the COVID-19 era, and in the COVID-19 era, we have also seen that in the non-intubated awake patients, there was also awake proning, and it has been endorsed by major guidelines. Regarding use of neuromuscular blockers, so in the before 2014, the famous accuracy trial was conducted, which showed mortality benefit in patients with moderate to severe ARDS. However, in 2019 ROSE trial, which included approximately 1,000 patients, there was no difference at 90 days mortality. So that's why the latest guidelines only suggest use of neuromuscular blocker in patients with severe ARDS. Coming to steroids, in the past, early use of steroid was discouraged, and late use had mixed results. It was beneficial to prevent the fibrotic phase of ARDS, but still data was inconclusive. So from 2014 till 24, we have seen landmark recovery trial, REMAP-CAP trial, which have shown that steroids are now standard in ARDS. So as per the guidelines, all the major guidelines have suggested early use of steroids. Fluid management, approximately 20 years back, FACT trial was conducted, which showed
ये the screen को देखें.
So approximately 20 years back, famous FACT trial was conducted, which showed conservative fluid strategy reduced the ventilator days. So this is still valid, and only exception is in the hyperinflammatory phenotype. They respond better to liberal fluid strategy, but still guidelines, all the major guidelines recommend a conservative fluid strategy. When you talk about the extracorporeal support, we have two devices. There is extracorporeal carbon dioxide removal, and there is extracorporeal membranous oxygenation. So first, extracorporeal carbon dioxide removal, basically it's a technique that removes the carbon dioxide from the blood using an external circuit. So how can it help my patient? Because it can help me provide ultra protective lung ventilation, which includes tidal volume of less than 3 ml per kg. So eventually this leads to eventually this leads to decrease in plateau pressure. So it helps, it can help any clinician to provide ultra productive lung ventilation, so decreasing the plateau pressure, eventually decreasing the mortality. But in the REST trial conducted in 2021, there was no mortality benefit. Additionally, the patients were at increased risk of adverse event, and most common was bleeding. So that's why it is not recommended. And when we talk about extracorporeal membranous oxygenation, after the Caesar trial in 2018, EOLIA trial was conducted, and the mortality benefit was seen, but the results were not significant. So that's why after 1 or 2 years, a Bayesian post-hoc analysis of the EOLIA trial was conducted, which showed probability of mortality benefit in severe ARDS. And in the most recent meta-analysis, we have seen ECMO significantly reduce 60-day mortality in severe ARDS. So when we talk about the guidelines, ATS, ESICM, also all recommend ECMO in patients with severe ARDS. When we talk about adjunctive therapies, so inhaled nitric oxide, it can improve the oxygenation, but no mortality benefit. We can use it as rescue therapy, only suggested by ESICM guidelines. Vitamin D, so based on the alveoli study conducted in 2022, vitamin D deficiency leads to increase in 90-day mortality, but there are no major RCTs on this topic. Beta-2 agonists, they should be avoided because they have led to increase in mortality. Statins, so HARP1 and HARP2 trials were conducted. So basically they try to target the patients with hyperinflammatory phenotype, but still they are not recommended. Vitamin C is not advised. There was increased risk of acute kidney injury. And interleukin-6 inhibitors, they can only be used in patients with COVID-19 with cytokine release syndrome, otherwise not in all other types of ARDS. So this is a summary slide in which I presented all the key management and all the recommendations. So to conclude my presentation, definition we have seen from 1988 till 2023, it's still evolving. Phenotyping, clinical and biomarkers, they can help us guide the therapy. And non-invasive oxygenation is now safer, and it is better with monitoring with ROX index. And the key pillars which can decrease the mortality in patients with ARDS: one, lung protective ventilation; second, steroids; and third is prone ventilation. And neuromuscular blocker agents can be used in selective cases, that is in patients with severe ARDS. And future, we can expect personalized and phenotype-based treatment. Thank you so much.
Thank you, Dr. Walid, for the elaborative talk and updated information on the management of ARDS. May I request Dr. Numan to please come onto the stage? We can have a few questions. Dr. Numan. I would like to have a comment on your talk. It was beautifully presented. About Numan. Do you have any local data about the implication of these guidelines? And second thing, which is very important in the pediatric population, is the IV excess. Do they recommend early intervention on going towards the central venous cannulations, or just it is the intraosseous?
There is no local data available right now, which I focused upon. We need local data and further studies to focused on these things. And about we can have in our scenarios we are using central lines for instead of IV lines if we are not able to find an IV lines. But the data which I presented, which is not from Pakistan, they're more focused on using intraosseous lines, which is easily accessible. But we need like proper training and guidelines to how to put this.
Dr. Fazal wants to ask a question.
Yeah, thank you. It's a comment and it's sort of a question as well. Wali, thank you very much for an excellent review of the happenings. And ARDS based, as you mentioned, like about 36 to 60% of mortality in Pakistan, as I understand. Don't you think this time, because we, the seniors, have failed miserably in identifying the incidence of ARDS in Pakistan. Myself and Madhya tried our level best 15 years ago. Now with advanced this diagnostic criteria, which is less sort of a invasive, is it possible for you and some young anesthesiologists or critical care specialists to identify the incidence actually? Because talking about a disease which is so lethal, and yet we don't even know the incidence of ARDS in Pakistan is not a good thing. Don't you think so?
So the major issue which I identified by preparing this presentation was lack of local data. So again, number one, we need good data. So for this, there is a registry in Pakistan currently which is getting data, but there is some good news for us, because while I was conducting the research, so before 2014, only 3 publications with ARDS were found from the Pakistan, and from 2014 till 24, I was able to find more than 50 publications, and some of them were published in JAMA, Intensive Care Journal, New England Medical Journal. So if I compare from tomorrow, so we are not progressing. But if I compare from 10 years back, so we are getting the pace.
Okay, my question for both of you. First of all, a comment, excellent presentation, both of you, and I'm very proud because, you both of you have been our trainees and I'm very proud of you. Achha, Numan, first question from you is this, that you said damage control resuscitation, right? And you mentioned about platelet and everything, but in the damage control resuscitation in pediatric patient, is there any role of 1:1:1 transfusion, which is commonly performed in obstetric and in military trauma patients? So is there any role of 1:1:1 transfusion for pediatric trauma?
Yes, I have mentioned this in my study that there
The
is
whole blood or 1:1:1?
1:1:1.
Okay.
Because there's a comparative studies with 1 is to less than 1:2 or more than 1:4 ratio or 1:1. The outcome is better in 1:1 ratio rather
Okay.
than the other. That's why I also
Rather than the whole blood?
no, there is no comparison between these two.
Okay.
These are two different studies in which we have compared 1:1 ratio with the other ratios like more RBCs than the plasma or the platelets. And whole blood is compared, is done in different studies, but we have not compared these two.
Okay, thank you. And one question for Walid, excellent presentation again. You mentioned about the new 2023 definition of ARDS. And one of the criteria was oxygen less than 97%.
Basically, so they have identified SpO2 FiO2 ratio of less than 325, but SpO2 should be less than 97%, because if it's more than 98%, so as per the graph of the hemoglobin dissociation curve, it becomes flat. So they are saying it's not reliable. So
Okay.
the SpO2 should be less than 97%, then we can calculate the
They
SpO2.
calculate the ratio
Then
of,
we can calculate the
FI.
ratio. If it's more than 97, then it's no benefit of calculating the ratio.
Okay, thank
I
you.
want to add one. There's a MATIX 2 study which I mentioned in this is going on, which is comparing low titer group whole blood versus the component therapy.
Okay.
There is a study going on. I think we'll get the results and we can compare it.
Okay, वो clinical trial में उसकी entry होगी ना?
Yes.
ST, अच्छा, ठीक.
Thank you very much. Excellent presentation by both the speakers. And since we are running out of time and we are going to conclude this session, thank you, both of you.
I would like to request the chairpersons to stay back and give the certificates to Dr. Noman Akil. Stage पे आके दो, ऊपर से आके दो, Dr. Noman Akil. जाओ. जी. Dr. Walid bin Ghaffar. I would like to request Dr. Hamid Ali to come on the stage to give the certificates to the chairpersons. Dr. Akhtar Aziz Khan. Dr. Jodat Salim. Dr. Hoba Ahmed. Sir, Dr. Hamid. एक सर्टिफिकेट वो फैसिलिटेटर बेचारी. Thank you, sir. Thank you. For the next session.